all of you for your critical care ground rounds. Let me just go ahead and share my screen. All right, that should be up for all of you now.
It's perfect.
Wonderful. So as Umesh described, I think we really are at a transition point in care of our patients in cardiovascular intensive care units. And the field of critical care cardiology is one that I like to think of it. We've passed the stage where we're in our infancy, but we are still toddling down the hallway, and we still have a long way to go. And I think that every day in my clinical practice, when I'm in the unit, I wonder whether we can move from doing what I learned to do from my mentors to what actually the evidence can guide us forward. And I think there's a huge gap there that we need to address. And that really will be a central theme of this presentation. I don't have any financial interest related to this particular presentation, but my grant support through the Brigham and consultancies are listed on this slide. And so I will spend a little more than 10 minutes or so really just introducing the foundation of the field and the epidemiological evolution that we've seen in our cardiac ICUs. That really is the basis for critical care cardiology and the needs that we have going forward. And then, as Umesh directed me, I'll spend the rest of the time really giving you a bit of a broad tour of what we've been doing in the research through the Critical Care Cardiology Trials Network as a bit of a window to the type of epidemiological work that we can do through large registries. And then I'll spend a few more minutes at the end describing what I think is next and how we're going to try and conduct more clinical trials in this space. But first, it is worth anchoring just in a bit of history and going back all the way to the early 1960s, where Desmond Julian first described in a meeting in the summer of 1961 at the British Thoracic Society his simple proposal in how we might modify the extremely high mortality rate of patients with acute ischemic cardiac arrest. And he had a series of 5 patients where they had started with closed chest massage in the early days in the Royal Infirmary in Edinburgh, and all but one of them had died. And he mused over whether it was the technique itself or whether it was the expertise of the people applying the technique was the critical factor. And so he just made a very simple proposal. He said, I think we should bring the people who are at most risk for cardiac arrest together, where we can centrally monitor them in specialized ICUs that we're going to staff 24/7 by particularly experienced personnel, and that everyone in that environment would be trained. So it would be not only the physicians, but nursing and all of the ancillary staff. And those 3 basic tenets, right? Regionalized specialty care, advanced monitoring, and specialized nursing, that is exactly the foundation of cardiac critical care today. Certainly it is in our institution where our specialized training for our nurses really is the backbone of what we do. Now, if we fast forward from that more than 25 years and go into our current era, we have seen progressively what was the reason that cardiac ICUs were born, which was aimed at the care of the STEMI patient. Now those patients are less than 15% in our cardiac ICUs. And Umesh and I were talking before we started that it's really the complexity of this population that has steadily grown over the past 20 plus years. And these data come from Shashank Sinha, who is now at Inova, analyzing the Medicare database, and demonstrated a steady trend in more than 3 million patients over this time period of increasing prevalence of non-cardiac primary diagnoses in this patient population, all of these restricted to self-identified cardiac ICUs. And then if you look at the medical complexity of these patients measured with the Elixhauser comorbidity score, where the deep purple is increasingly complex, you can see that that group of patients is increasing steadily over time, so that now by 2013, the majority of patients are in this highest complexity group. And that certainly reflects my experience every day in our cardiac ICU. Jake Genser, who at Mayo, has looked at this in their enormous database from 2007, more than 12,000 patients, demonstrating a progressive increase in the proportion of patients with multi-organ failure. And then that the organs that are failing are increasingly non-cardiac. So it's the renal failure, it's the respiratory failure, it is the cognitive dysfunction. Those are the things that are driving morbidity and often mortality in our cardiac ICUs in the present era. And so as my first real key take-home point, we've seen this steady evolution from coronary care to really true cardiovascular critical care, a steady decrease in acute coronary syndromes in our unit. We're not seeing the cardiovascular conditions in isolation, but with an array of other medical comorbidities that we need to care for. And a point that I didn't discreetly make yet, but is one that I always make to our residents and fellows, is that often the cardiac issues that were primary on day one become secondary to the ICU complications of the care we're providing. And that's really what drives morbidity. And so we need to learn from the experience in other critical care environments and in general critical care that has driven the care of this type of patient in multi-organ system failure for a long time. And I'd say that lesson number one comes around the staffing of ICUs. And while there is no single perfect trial, Peter Pronovost has pooled together the data from more than 13 studies and analyzed ICU mortality and ICU length of stay with a high intensity staffing model versus other alternatives. And what he demonstrated was that overall, as this group is very familiar with, favorable impact on mortality, and here in non-randomized data, 39% lower ICU mortality with a high intensity model, and a lower ICU length of stay as well. And so when you look at the cost of care, we can also see a translation. So these data come from Robert Wood Johnson, 15-bed mixed medical ICU, pre and post implementation of the Leapfrog staffing guidelines, which included also switching to an ICU-based model of intensive care. And you can see that the length of stay was reduced from the pre versus the post, that also the infection rate in terms of CLABSI was reduced significantly over that time period. And vent-associated complications, including VAP, were also significantly reduced over that period of time. Well, that translated into more than a $1 million worth of savings, some of which was related to ICU stay and others related to the complications of care. And certainly if we can improve outcomes, reduce length of stay, and reduce cost, we would want to achieve that in our cardiac ICUs, just as that model may be achieving in our general ICUs. And so as part of a writing group that I led for the American Heart Association in 2012, we also conducted a survey of 123 cardiac ICUs around the country. The majority, so more than 3/4, were academic. Most of them, so 68%, were dedicated cardiac ICUs as opposed to being mixed surgical or mixed medical cardiac ICUs. And just over 1/3 of them had a high intensity model where it was ICU-based staffing of the ICU as opposed to an open unit. And so when we look at the participation of intensivists in the care, so at least individuals with critical care medicine training, you can see that in the majority, there was, as a single field, the majority had critical care consultants that were at least available to them. But still, it was less than 50% that had routine involvement of a physician with advanced care, advanced skills in critical care medicine. And it was a vast minority, less than 5%, where the managing primary attending in the unit had critical care training. There may be collaborative care in many of those environments constituting the remainder, but it was less than 5% where the primary attending had critical care experience or formal training. Now that had increased already from 2012 to 2016 by the time that Sean Van Diepen conducted another survey within the American Heart Association. And a quarter of those institutions all indicated that things were changing and that they were hiring. And so this has really been a field, as Umesh pointed out at the beginning, that has been in somewhat rapid evolution. Now, since that initial survey came out, we also now have data specific to cardiac ICUs. And there have actually been 3 published studies, but I'm just going to take the time to show you the most important one. So these data come from Korea Tertiary Care Center in Korea. For any of you that have visited this hospital before, it's rather remarkable. Their technology rivals, if not supersedes, what we have at the Brigham. It is a high tier quaternary institution. And in their 12-bed medical CICU, they transitioned from an open unit model to a high intensity staffing model. And in the prior model, there were senior residents who took care of the patients in the ICU with the patient's general cardiologist that followed the patient into the ICU. And then after the transition point, they followed for several years. So it was a total of 3 years of follow-up after the transition. They were rounding with the residents with a cardiac intensivist supervising all the care of the patients in the unit, who was available 24/7 for care of patients in the ICU. And what you can see is that in blue, compared with the purple, you see the high intensity model. Cardiovascular death was lower. Non-cardiovascular death was lower. Sepsis as a complication was lower, as was actually all bleeding in this population. Now, obviously, there are a number of other changes, and patient population may change over that period of time. So they performed a propensity matched analysis. And in that propensity matched analysis, the CICU mortality was still 47% lower after this change. Now, we cannot possibly attribute it all to staffing. There may have been changes in the way they round, with having a pharmacist on rounds. There may be structured changes in what they use for their ICU checklist for safety and VAP prevention and CLABSI prevention on rounds. It's certainly a bundle. But if you could implement a bundle that would lower your CICU mortality by nearly 50%, certainly you would want to do that. And so I think that our charge going forward is to really dissect the elements of care that come with high intensity model as we try and guide the organization of CICUs of now and of the future. And so my key second point is that the reorganization of care in CICUs is following this high intensity model that in general ICUs has improved safety, saved lives, and reduced cost. And that present CICU models in the US are extremely heterogeneous. They are not all like your Mount Sinai cardiac intensive care unit, and the minority are still using high intensity staffing models. But over the next 5 to 10 years, that is going to change, and it already is. And there are a lot of people who care about this because quality is at risk, and also large amount of healthcare dollars are at risk as well. And so there are many people outside of our cardiac intensive care units who care about what we're doing and are regulating and monitoring our progress in this area. So in those first minutes, I built a foundation on why the epidemiology has changed. We've talked about models of care delivery in cardiac ICUs. And now I want to transition to talk about the research. And certainly in the Q&A at the end, I'm happy to talk about education and training. I took that part out of this lecture so that I could focus on the research end of things as Umesh had asked me to. So as just one case illustration, I want to start with an example for a decision that we make every day in our cardiac ICUs. So if we go back to 1976 and look at the best guidance that we had regarding invasive hemodynamic monitoring, it was from Forrester's original paper in the New England Journal of Medicine. And the recommendation was to use invasive cardiac monitoring for patients where there was diagnostic uncertainty or loosely the treatment required monitoring. Now that really seems very non-specific and doesn't give us a lot of guidance. But if we go to 2017 and the AHA scientific statement on cardiac critical care and the management of shock, we see that the statement is to use pulmonary artery catheters in cases of diagnostic uncertainty, management uncertainty, or in patients who are unresponsive to initial therapy. So as we go from 1976 to 2017, there is fundamentally no change in our general guidance for the use of pulmonary artery catheters and invasive monitoring in our cardiac ICUs. And the reason for that is really inadequate evidence. We have at minimum mixed evidence. So on the left-hand side is one of the few studies that evaluated randomization in patients with shock. The ESCAPE trial, as you're all familiar with, was in patients with heart failure, but without shock. In shock, we have data from a mixed trial, mostly septic shock, a third of patients with ARDS, randomized within 12 hours of meeting criteria, and there was absolutely no difference between the PAC managed patients and the control group. But I think most of us on this call will reflect that we don't know if this trial is reflective of the type of patients that we care for, certainly in our current day cardiac ICUs. Now, on the right-hand side, we have observational data from the Cardiogenic Shock Working Group. So 1,400 patients over a 3-year period of time. And what they observed was, in a non-randomized analysis, was that the 42% of patients in gray who had a PAC with complete hemodynamic data that were recorded, that those patients had a demonstrably lower mortality in a propensity-matched analysis, down in gray at the bottom, compared to those patients either who had no pulmonary artery catheter or who had a PAC with incomplete recorded hemodynamics. Now, it's a little bit complicated to interpret because I don't know why one would have in a pulmonary artery catheter and not actually use the data, but we can see these observational data suggest that there may be a role for pulmonary artery catheters in our patients in the ICUs with lower mortality associated with the use of complete hemodynamic characterization. And I'm going to come back to this later in the talk. But I think it is clear from what we have that we need additional information. We need more data to guide this decision making, and we really would ideally have randomized data in the current era of care. And so there are innumerable questions that we face in cardiac critical care every day when we step into the ICU. We do not know about invasive monitoring in cardiogenic shock, as we just talked about. The timing and device selection for mechanical circulatory support is extremely uncertain, as our only adequately sized randomized clinical trial showed no benefit of balloon pumps, at least in the AMI cardiogenic shock population. We don't really even have a good evidence base to know what the best initial vasopressor should be. We have observational data that guide us to 65 as a target map, but we have very poor data to know that that is the right answer, although we do it all the time. Use of TTM is evolving, as we know, and certainly a complicated field. Mechanical ventilation strategies in patients with cardiogenic shock are largely untested. We don't even know what the right sedating regimen is to use in our patients who are at risk for cardiovascular complications. Virtually everything that we use for sedation in our ventilated patients in the ICU. And the list goes on and on. And so my third key point is that there is a glaring need for additional research to support evidence-based care in this environment. Many common essential issues that we do not know the answer to. And we've learned multiple hard lessons previously based on extrapolation from observational research, with intra-aortic balloon pumps certainly being one of our best examples in cardiac critical care. But it is a challenging environment for clinical trials, and maybe we'll talk more about that at the end. Consent is difficult, equipoise is difficult, the stakes are extremely high, and most of our interventions come with relatively high risk. So these are not easy trials to run in this complex environment. And so with that in mind, we started the Critical Care Cardiology Trials Network in 2017 with the mission to design and execute observational studies and clinical trials that will advance the care of patients in this domain. And I want to personally and directly thank Dr. Gidwani and Dr. Leibner and Maria Ronquillo, who's entered much of the data for your site in C3TN, and Matt Tomey and Hassan and Atanuki as well, all of your team who've been critical to the success of C3TN at Mount Sinai. And you all have been participating in what has grown to be a, we hope, rather impactful network of critical care centers conducting research in critical care cardiology. We've gone from 19 Vanguard centers in 2017 to now 40 participating sites in 2022, and we continue to grow across North America. And in our registry, which captures snapshots from every year in C3TN, we now have more than 25,000 admissions, all to cardiac intensive care units captured consecutively. That has enabled all of the research I'm going to show you in the next 20 minutes or so. And so this was one of our first papers. That's Aaron Bahula, depicted over in the left corner, who was the lead on this particular study. And this described the first 3,000. So we're now up to 25, the first 3,000 admissions to the registry. And what you can appreciate already is that we are not just acute coronary syndrome, right? It's that 15% I mentioned already for STEMI, only 30% overall. And I must say, on a daily basis, it feels like it's all heart failure in our ICU, but actually the majority that are admitted primarily for heart failure ends up being only about 20%. And it is a plethora of other patients that we are caring for, including those with complex arrhythmias needing ablation and complex interventions and VT storm, as well as patients, a broad group of patients with structural heart disease that are ending up in our ICUs either before or after procedures for care. And then many of our ICUs, I know this is true for you at Mount Sinai, end up taking care of patients with non-acute cardiovascular illness as well around the country. And so it is not just one size fits all for sure. Now, if we look at the indications for intensive care, it's not surprising that shock and respiratory insufficiency might be the main drivers of admissions to cardiac ICUs. Arrhythmias and need for pressors are the next most frequent two. What was somewhat more surprising to us is the large proportion of patients who were admitted to cardiac ICUs without what we might regard as a hard indication for intensive care. That many of them are for post-procedural observation, and many are simply for the need for higher level nursing care or monitoring. And that still may be most appropriate, depending on the staffing in your intermediate care units. But that was a notable finding for us. And that translates into the advanced ICU therapies that we see. And so again, inotropes, vasodilators, invasive hemodynamics, MCS, mechanical ventilation dominate. But it turns out that on average, 40% of patients admitted to our cardiac ICUs around North America don't end up needing any of those traditional ICU level therapies. And certainly our hospital administrators are paying attention to that number and wondering whether we could do better in triaging our patients who need cardiac intensive care. And so there's huge amount of variability across institutions. So the height of the bar in this slide represents the proportion of admissions that don't require any invasive monitoring or advanced ICU care. So that includes no need for a pressor, no need even for continuous IV nitroglycerin, no MCS, no renal replacement, no non-invasive or invasive mechanical respiratory support, and no ICU restricted therapies, whatever those might be at their hospital. In one hospital, 60% of their cardiac ICU patients actually didn't require any of those therapies. And so this is an area of active work. Sean Van Diepen in particular is working on triage algorithms in cardiac ICUs and trying to test them prospectively to potentially impact the cost of care. Now, if we look at mortality, not a big surprise that our patients with cardiac arrest and cardiogenic shock still have mortality rates that are around 30%. I'm going to come back to the shock population in some detail in just a little bit. But those patients who came in for observation alone in need for hemodynamic monitoring, their mortality rates are extremely low. And if we focus on acute coronary syndrome patients as a particular group, you can see, again, wide variability across ICUs around the country. And wherever there's variability, it means that there are differences in care, and it means that there's uncertainty in the field, and that there may be an opportunity for improvement and standardization. And the Brigham happened to be at the low end of this when we do not admit many patients with ACS to our ICU. And so Aaron Bahula and Antonio Del Fuentes looked from our group to see what happened to these patients. And overall, those patients with ACS had a lot less hard ICU indications. More than half of them were admitted only for monitoring. And then when they looked at the outcomes in those patients, only 3% of them actually went on to require an advanced ICU therapy. And the mortality rate, again, in those who were only in the ICU for monitoring was extremely low. So this is certainly a population that I know at Mount Sinai, it's similar to the Brigham, where our ACS patients all go to intermediate care unless they're in shock, they're electrically unstable, or there's some other complication of their procedure. They end up going to our step-down unit. So I want to spend some time on shock because that certainly is an area of particular interest for us in the C3TN, and no doubt is one of the major areas of interest for you clinically, because it's a group that still has such poor outcomes and requires the most advanced decision-making. And so the work that we've done in C3TN has really been quite enlightening, revealing a shift in the epidemiology of shock in our cardiac ICUs. So first, if you just take the overall snapshot, you can see it's only 2/3 of the shock in our cardiac ICUs that is purely cardiogenic. We have a large proportion of patients with mixed shock, mostly vasoplegic on top of cardiogenic, but also there's some hypovolemic, there's some distributive, and there's some uncertainty as well. Now, if we drill down to those patients with cardiogenic shock, no longer is it acute myocardial infarction cardiogenic shock that dominates in our ICUs. It is heart failure progressive to cardiogenic shock, whether it be ischemic or non-ischemic. Also, all of our patients with arrhythmias and valve disease who present in shock, those are the dominant patients in our cardiac ICUs now in 2022. Now, not all shock is the same, right? It varies by phenotype, but it also varies a lot by outcome. And so we've all learned from the SKY staging effort that has been undertaken across the country and led by multiple disciplinary group at SKY, that if we go from those who are at risk from shock to those who are in extremis with severe acidemia and elevated lactate, that there is a spectrum of risk. But what's notable is that those patients with classic cardiogenic shock, where we are not rapidly escalating care, that those patients actually have a mortality rate, in a hospital mortality rate, that's only about 15%. So not all shock is the same. And this really underscores one of our major jobs ahead of us, not only for epidemiological research and clinical trials, where we need to know who it is that we're talking about, but also in prognostication for families when patients first hit our ICU door, as well as potentially phenotyping for directing our advanced therapies to the patients who need it most, but still might have an opportunity for benefit. And so this is one of the areas that we've been expanding on in the C3TN in a number of different ways. The first lens here is, can we simply stratify risk effectively from the get-go when you first hear about that patient from the emergency department? And this is an analysis led by Sid Patel, who's one of our critical care cardiology fellows. And what he showed was 3 simple measures plus 1 additional, platelets. When you hear about a patient in the ED, when you first hear their pH, their lactate, their creatinine better reflected in their eGFR, you know where things are headed. And remarkably, using those 3 things together in a simple score actually did a remarkably good job about risk stratifying patients in both the derivation cohort, going from a risk of only 3% up to nearly 75% in-hospital mortality, compared to a validation cohort, where in a separate cohort within C3TN, we found exactly the same. And then we also validated it in the Mayo database as well. And you can see extremely high level of calibration between these data sets. The other area that we've been making strides is really diving more deeply on these subphenotypes of shock. And so this slide comes from the Cardiac Safety Research Consortium work that has been done in the Shock ARC Collaborative, the SHARC Collaborative, to develop definitions and nomenclature for research in cardiogenic shock. The manuscript for this effort is still under embargo, but this slide has been shown publicly before. And we have started to develop a more refined nomenclature that discriminates those patients who have heart failure cardiogenic shock, where the primary etiology is not acute myocardial infarction, from those patients with secondary cardiogenic shock, which is those with primary non-myocardial drivers. So the patients who present with refractory arrhythmias, pericardial or valvular disease. And then also discriminating those with de novo presentations versus acute on chronic presentations as well. And we've been diving more deeply into those groups of patients within C3TN, and these data come from Dave Berg and Ankit Bhatt, one of our fellows who graduated and is now at Kaiser. And what we found was that when we look at their distribution of SKY stage, you can see that there is a remarkable difference between acute on chronic, with generally lower SCAI stage in the acute on chronic population compared to AMI cardiogenic shock and de novo heart failure cardiogenic shock, but also that the mortality rates differ. And so maybe not a big surprise intuitively as we think about it, but certainly the first time we had demonstrated in a large data set that the mortality rate was quite similar for those patients without AMI and presenting with acute cardiogenic shock versus the acute on chronic cardiogenic shock population that we take care of. And he demonstrated, despite very similar hemodynamics, very marked differences in end organ injury across these patient populations. And so mixed shock. This is another group of patients that we are grappling with in our cardiac ICUs. It is so often whether they get to us as the chronic heart failure patient who now is infected and has mixed distributive and cardiogenic shock, or whether it's the patient who comes in initially pure cardiogenic shock, has mechanical circulatory support, shower of cytokines, profoundly vasoplegic. We see this quite frequently in your practice, I'm sure. These patients are sicker with more end organ injury. They stay in our ICUs longer. They require more mechanical ventilation. They require more renal replacement therapy. And in general, they require more vasoactive agents with greater use of pressors rather than pure inodilators. And then when we look at their mortality rate, and I'll just highlight the red, which is in-hospital mortality, you can see certainly this group is no lower and may in fact have the highest mortality rate among these different groups of cardiogenic shock and mixed shock that we take care of in our cardiac ICUs. And so this group of patients really has a lot of unanswered questions that we are probing in the critical care cardiology trials network. Now, what about mechanical circulatory support? Certainly, we love our toys in our cardiac ICUs, and our centers in C3TN are no exception. And as we've been drilling more deeply, we've learned a lot. So here are the indications for temporary MCS across the first snapshot of shock in C3TN. And we are updating these analyses now as we've gotten to that 25,000 patients, a much bigger cohort. And you can see it's about a third. A third are acute MI with cardiogenic shock, a third are cardiogenic shock without AMI, and then a third are the rest. People who got devices placed for procedural support or for an indication, other indications other than shock, preemptive, going for a VT ablation, and then also with mixed shock as well, or unrevascularized coronary disease, for example. But when we dive more deeply, here again is where we start to see data that are eye-opening. So first of all, when you look at the overall cohort receiving shock in 3C3TN and drill down just on the cardiogenic and the mixed shock patients, we see it's a third of patients that end up receiving MCS as a part of that. Now, 72% of those still balloon pumps. I know if Holger Thiele were on this call, he would say, what are you doing? We don't even have a balloon pump in our hallway anymore for cardiogenic shock in Germany. We have a randomized trial that gives us an answer. But in North America, we're still using mostly balloons. But then when we look across each of the sites in C3TN, again, a rate that goes from only 17% up to a half of the patients receiving mechanical support. And I can tell you from the very careful analyses that Dave Berg did in these analyses, this particular study, it is not driven by patient characteristics. So the individual centers actually overall behave in a fairly similar way around patient risk, but there are large institutional differesences in practice. And one window to that was an analysis that Sunny Varshney, one of our fellows who is now at Stanford, did, where he looked at pre-post the change in UNOS allocation rules in 2018. And if you look at transplant centers versus not, and I'll just bring you over to transplant centers first, that if you look pre-change to the UNOS allocation versus afterwards, there was a significant increase in the proportion of patients receiving mechanical circulatory support for shock in a propensity-adjusted analysis. And most notably, if you go to those CICUs that were in non-transplant centers, absolutely no different pre-post. So no difference in the amount of MCS pre-2018 versus post, whereas in transplant centers, a dramatic increase in the use of MCS. And we did a number of falsification analyses with other ICU therapies, with mechanical ventilation, others that are not directed necessarily at cardiogenic shock. And we found that there was, again, in transplant centers, no difference pre-post. So it's not just a change in the way we're approaching care. Now, what can we do that maybe helps patients? Well, maybe we can organize better. And so we certainly have a number of studies, 2 notable ones now, 3 actually, that support the notion that a transition to development of a shock team is associated at least with improved outcomes. And so these data come from C3TN. It's the only multi-center analysis that has been published so far. And we looked at those centers that had a shock team versus those that didn't, and again, conducted a propensity-adjusted analysis. The number of shock patients was similar, around 600 in both. The proportion with AMI was similar. Emission lactate was identical. Pulmonary capillary wedge pressure, extremely similar. Cardiac index, very similar. Cardiac power index output, also very similar. Yet, in those with a shock team in the dark blue, more PA lines were used. Now, interesting, overall, there was actually less use of mechanical circulatory support in those centers with shock teams, but the proportion of patients who had advanced non-balloon mechanical circulatory support was higher. And then overall, in the propensity-adjusted analysis, we saw a lower mortality in those centers with a shock team. Again, it is very difficult to impute a causal relationship in this type of observational research, but is the best that we have so far. There is no randomized trial of shock team versus not that exists today. The other area that I think is extremely important in critical care is our end-of-life care. And so that is another area of interest for us in the cardiac ICU. Here we studied 8,000 admissions. This was after our, I think, our second campaign. CSU mortality overall was 10%. 2/3 of patients ultimately were CMO in our cardiac ICUs. Of those patients, 1/4 of them received mechanical support, renal replacement therapy, and more than 3/4 of them had mechanical ventilation before going CMO. And the minority of them, the vast minority, were DNR and admission. And then if we look at timing from ICU admission to CMO, you can see that there's a long tail to this. And the majority of patients, or a large proportion of patients at least, were more than 72 hours before they transitioned to CMO. Yet once they transitioned to CMO, the vast majority died within 6 hours. And so the high use of invasive therapies, the relatively delayed time to CMO decision-making, and the rapid progression to death makes us at least wonder whether there's an opportunity here for earlier institution of end-of-life palliative care, or at least involvement in advanced decision-making earlier on in the course of these patients. And maybe we'll talk about that at the end. I just want to show these data briefly just to emphasize we care about other things. It's not all mechanical cardiac devices that we're focused on. We also care about other aspects. We have publications on renal replacement therapy, and this is just one example with advanced respiratory support in our cardiac ICUs. And it makes intuitive sense that those patients who require invasive mechanical ventilation have a markedly higher mortality. But it is notable that in absolute terms, above nearly a 35% mortality rate in those patients who required invasive mechanical ventilation in our cardiac ICUs. It is a sick group of patients and maybe a population where we should be using better strategies for ventilatory support given the hemodynamic implications. But that is largely an untested area in terms of direct evaluation of different strategies. So in just 4 minutes or so, and then I want to stop for questions, I'll speak to the future and the near future in critical care cardiology. And I think we've already laid the groundwork. Their expansion of critical care cardiology registries. There is international collaboration is a priority. There are health systems that are developing into learning health systems and using their data iteratively to improve care. Pragmatic clinical trials, I hope, will be part of our future. I think we still have to prove that we're capable of doing that, but I think it has our best shot. And then deep phenotyping in translational research to really sort out this broad spectrum of shock patients and hopefully guide new therapeutic strategies, I think is going to be at the center. The ACC is now a leader in this area. There is, as of March of this year, a critical care cardiology section. For those of you who haven't heard about it and are interested, please feel free to join, make your voice heard in how we direct critical care cardiology around the country. And then the AHA has initiated the Cardiogenic Shock Registry, which also launched in March of this year and is aimed to be a very broad representation across the entire country of systems caring for patients with cardiogenic shock. It is a multi-stakeholder environment with active involvement from the FDA, CMS, and industry. And our hope is to build an efficient infrastructure to support pragmatic, prospective clinical trials, as well as the type of epidemiological research that I've been showing you. We also have small pragmatic trials that are already starting. This is the PACS trial design that you may even be participating in, led out of the Cardiogenic Shock Working Group with many stakeholders, including Naveen Kapoor, Dan Burkhoff, and Shashank Sinha was the one who showed this slide at ACC. 400 patients that are going to be with heart failure cardiogenic shock that are being randomized to a pulmonary artery catheter. I think this is updated to 6 hours now in their current protocol, versus those who have no PAC or delayed a minimum of 48 hours after randomization. I certainly applaud this type of research that is very difficult to do, and it is going to be enlightening whatever the outcome from this randomized clinical trial. And then lastly, I want to highlight the effort in deep phenotyping. This is work that our group is doing to try and understand the biomarker profiles in cardiogenic shock. We have more than 1,000 patients in our ICU registry now with all comers to our ICU, where we are collecting samples. And we have started to do, I'm going to skip this slide, and we've started to do deep phenotyping. This is with a proteomic analysis. So this is using 3 different of the Olink panels, which is a multiplex panel that allows us to, in this particular analysis, study just under 450 proteins. And in that, you can see this is a volcano plot where everything in red passes a Bonferroni threshold. And even with that, there's still a large number of significant proteins. If we go up in the upper corner, it's nice to see that natriuretic peptides are still showing up, so as predictive. But we identified 3 that already have an existing literature and are all in this upper right corner, FGF23, GDF15, and soluble ST2, where if you use those markers, there is a more than 200-fold higher probability that that patient had cardiogenic shock as the final diagnosis, as opposed to another form of shock in a cardiac ICU. Now, this is exploratory research. It is a small sample size, only 69 compared to the other ICU controls. And we're using this to guide future steps in validation and hopefully bring this type of research to the entire critical care cardiology network for all of those that are interested and have the capabilities. All right, so in closing, I just want to summarize that our cardiac ICUs have evolved toward greater complexity. Multi-system organ failure and management is now an inherent priority. Team-based care is the name of the game, with multidisciplinary care as the way we approach everything. I think I've hopefully shown there are huge gaps in variability in care across cardiac ICUs that give us ample room to move from just what we do because it's what we've always done, to more evidence-based practice in our cardiac ICUs. And I think that the solutions are going to involve learning from epidemiology, development of strategies for pragmatic clinical trials, and hopefully feeding back all that we know into learning health systems so that we're constantly learning from the data we gain from these quality improvement efforts. So I want to stop there, and I welcome any questions that you all have.
David, thank you so much for coming and giving us this talk. It's amazing, and we really enjoy being part of the CTN trial network. And I promise I will be getting your data back.
Our data queries.
Data queries back to you. I've been working on it.
Thank you.
My first question that I wanted to ask is, what do you think is the future of cardiac critical care training? I know some of the sites have these special advanced fellowships for people who are interested in cardiac critical care. Some of them are for cardiologists who did critical care. Some of them are for everyone who's done critical care. And then do you see specific fellowships becoming more common? Do you see specific boards coming for cardiac critical care?
Yeah, so I'll answer the easiest part of that first, which is to say, yes, I think that certainly this is the direction that we're moving. And I think that dual training is going to be eventually the predominant form for major academic and tertiary quaternary centers. How you get to that, I think there's a lot of room for variability. I think that we have trainees that go through critical care training first, get the bug for cardiology, and then go do a cardiology fellowship. We have trainees who finish their cardiology fellowship and then realize they really want to practice and have their professional focus in a cardiac ICU. And I think those individuals benefit from the additional training in critical care. And so I think that training in both is likely to become an expectation, but I think there are a variety of ways you can do it. And I think there are going to be more and more programs that offer an integrated training. Now, because we already have boards in critical care and we already have boards in cardiology, and it costs a lot to create new board exams and to execute those, I don't know. I don't know if we will ever end up in a place where we'll have a specific separate board exam. In Europe, they do have a ACVC certification exam, a critical cardiology certification exam. We might move in that direction, but I think that part of the story is untold.
Thank you. I'd like to open up to anyone else who have questions for Dr. Morrow before we run out of time.
David, this is really, you've really established a template for how a specialty or subspecialty should grow. Research-driven, rigorous seeking out of evidence, and basically changing with the times, all, from the full spectrum, from the type of MCS to genome-wide associations. It's fantastic. Thank you so much. And as you can see, Evan is a very important part of a cardiac critical care team. And we thank you very much for spending time, and we're going to have you back again. And in the background, we'll talk about some of the other thoughts that we have about research opportunities.
Yeah, could I inject the last issue? I don't know if you can hear me, and that is one of the major issues is lack of adequate sleep in intensive care units. Lack of sleep has a major effect on the inflammatory response, on the immune response, and I'm just wondering whether or not we should be looking into that as a component of improving care for our patients in critical care units. They are totally sleep disrupted, noise as well as procedure. We wonder whether that could be something that could be improved by the critical analysis and study.
Yeah, no, I'm glad you raised that. I take it even to the next step, which is, I must admit that the problem I have the most difficulty managing every time I'm on service is delirium. And so, you know, the contribution of sleep deprivation and disrupted sleep cycles to that, and the morbidity that it causes when patients have prolonged ICU stays, and particularly prolonged time on the ventilator because of it, is hugely impactful. So I think that is a perfect area for us to work on. And there are so many that we have a lot to take on in the next few years, but that should be one of them.
David, thank you so much. We really appreciate your time.
My pleasure. Thanks
Have
so
a good
much.
rest of your day.
Yeah.